Good morning, everyone. It is now 10 o'clock, and I want to get started on time. My name is Dr. Renee Cassidy. I am one of the co-chairs of the Regional Overdose Prevention Coalition, and I'm pleased to be your moderator for this morning's panel discussion. We are going to open first with a presentation from each of our panelists, and I also want to start with thank yous. So we would like to express our thanks to Prevention Point Philadelphia and the Health Federation of Philadelphia for loaning their expertise and technology, as well as a space to meet, and especially to Martin, Caroline, and Morgan, who have helped us behind the scenes. I'd like to express my thanks to the rest of the executive committee who've done a lot of work behind the scenes, and to Vital Strategies, who's provided a grant to help us put on this conference. So we are going to start by introducing our panelists. Secretary Jennifer Smith, who is the Secretary of the Department of Drug and Alcohol Programs for the Commonwealth of Pennsylvania. Secretary Smith was recently reappointed for Governor Wolf's second term, and she has really helped increase harm reduction in the state of Pennsylvania in her efforts. Welcome, Secretary Smith. We're so pleased that you could join us.
Thank you so much, Renee. I appreciate it. Very glad to be here. Renee, would you like me to get started, or were you introducing all the panelists first?
Go ahead and I'll introduce the panelists in between. Thanks.
Great. So I am going to share my screen here. Hopefully everyone will be able to see this. Okay, Renee, can I get a thumbs up if we can see that? Perfect, thank you. Good morning, everyone. I am Jen Smith, excuse me, Secretary for Pennsylvania's Department of Drug and Alcohol Programs. Thanks so much for the introduction and for the warm welcome, but most importantly, thanks for inviting me to participate. I was really thankful to hear some of the opening comments from the counties about what's happening. It's so important. It really is a pleasure to be with you. It's events like these that serve as a reminder that we're all in this together. Helping to better the lives of individuals with substance use disorder is truly a collaborative effort, a sum of all the parts approach, if you will. As members of the medical community, behavioral and public health fields, law enforcement, public policy, people and families in recovery, and others, your role is vital in addressing substance use disorders and in doing your part to make a difference in someone's recovery journey. The partnership of public health, public safety, and community supports is a really critical one in responding to this crisis. It goes without saying that you are all here because you care deeply about improving the lives of those affected by substance use disorder. Whether it be through personal experience or the experience of a family member, friend, or colleague, we all know someone whose life has been changed by this devastating disease. Thousands of Pennsylvanians are affected every day by the disease of addiction. As a state and a nation, we're all still trying to find our way through the impacts of 2020. Throughout the last 15 months of the pandemic, we know it's been a time that's brought about uncertainty, anxiety, financial stress, and isolation, all risk factors that could increase usage of substances or result in a recurrence of use. We're continuing to evaluate the overdose trends from 2020, but as you can see, the numbers are already showing increases from recent years. And we expect the numbers to continue to rise as we continue to form the complete picture. The work you are all doing must continue, and it has to do so with a shared understanding. We must all resolve to continue doing our part to address this crisis. The Wolf administration is doing just that as we continue to digest the impacts of the pandemic here in the state. As we navigate the coming months and the impacts on individuals with substance use disorder, DDAP and our partners within the administration are committed to continuing the fight to ensure all Pennsylvanians have access to necessary life-saving resources, including harm reduction services. We have learned a lot and come a long way in expanding access to vital services and improving outcomes for individuals with substance use disorder. But there's a long road ahead. We know that being able to use community-based services and having access to programs and resources are more vital than ever before. For instance, by working collaboratively with stakeholders, providers, and advocates throughout the pandemic, we have expanded access to drug and alcohol treatment services and life-saving harm reduction services. As a whole, we know that in order to reduce the human and economic impact of the disease of addiction, we must address the root causes, the biggest of those being stigma. Stigma reduction is at the core of DDAP's four-pronged strategy that outlines our goals and works to promote recovery. DDAP is committed to mobilizing our efforts to further educate the public about the science of addiction, reducing stigma by utilizing first-person language, sharing hopeful stories of recovery, and informing the public why it's harmful to discuss substance use disorder as a moral failing. This is why we've partnered with Penn State University's Douglas W. Pollock Center for Addiction Outreach and Research, the Public Good Projects, and national nonprofit Shatterproof to implement the Life Unites Us campaign. Pennsylvania is the first state in the country to address substance use disorder stigma with an evidence-based campaign with proven results. This campaign utilizes social media to spread real stories of individuals or family members of individuals who have journeyed through their active addiction and are living happy, healthy lives in recovery from substance use disorder. In May, the campaign officially hit its year-one milestone by reaching 3 million Pennsylvanians on social media platforms. Life Unites Us has also shared tools and information about stigma reduction to more than 350 community-based organizations across the state. Another aspect of the campaign is its utilization of webinars, which have been attended by more than 1,000 Pennsylvanians. With all of these successful results, we do recognize that stigma runs deeper than the obvious perceptions about the disease itself and the people who suffer from it. Stigma also surrounds the use of naloxone by law enforcement, the treatment of overdose victims in the hospital, the use of medication as a means of treatment, the role of harm reduction services in communities, the placement of recovery houses, and even the varying pathways to and through recovery. We are working to tackle as many of these problematic perceptions as we can. For example, increasing access to naloxone has continued to be a priority, and our efforts in this regard have grown by leaps and bounds over the last 3 years because we know naloxone saves lives. Through a partnership with Next Distro, individuals across Pennsylvania can watch a training video and receive naloxone by mail, free of charge, to their home. Utilizing the Department of Health's naloxone standing order, individuals are also able to obtain naloxone at their local pharmacy. And this past March, the Pennsylvania Commission on Crime and Delinquency announced the availability of the statewide naloxone allocation request portal. This portal allows eligible organizations that serve high-risk populations, such as harm reduction organizations, the ability to request additional naloxone nasal spray directly from the state. All of these efforts are in addition to the process for centralized coordinating entities within each county to request product directly from PCCD. With these resources, All residents of Pennsylvania who are at risk of experiencing an opioid-related overdose, or who are family members or friends of someone at risk, can now get naloxone free of charge. This is just one example to illustrate our commitment to addressing the opioid epidemic in Pennsylvania. We're also working with our partners at the Department of Health to allow for syringe service programs to operate legally in Pennsylvania. I can hear the round of applause from some of you. When someone is using drugs, oftentimes they're afraid to make use of services that can help them because of the stigma associated with substance use disorder. There's that stigma again, always at the root. The fear of discrimination, imprisonment, and overall shame are very real barriers for a person with substance use disorder seeking services. Harm reduction efforts are so important because they're aimed at simultaneously building trust and reducing stigma, while also encouraging the belief in and respect for individuals using drugs. Unfortunately, the harm reduction community is subject to the negative effects of stigma, specifically when it's perceived as a means of enabling. To those who believe this theory, I would say the only thing that harm reduction strategies enable people to do are to keep themselves safe while they're engaging in behaviors that might be harmful. Reduce transmission of HIV and hepatitis C, enables them to be honest about their use of drugs and their behaviors, and enables them to see their own strengths and what they might be capable of. Harm reduction strategies are vitally important, like connecting people to healthcare services, providing clean needles and supplies, and engaging these folks with programs and services available in their own community. This could include housing, treatment, medical care, or employment. The National Institute of Health reports that of those individuals who inject drugs, people who have access to clean needles reduce risky behaviors by almost 80%. I don't know about you, but I like those odds. We know that harm reduction can improve overall health outcomes, make drug use safer, and potentially provide a pathway to treatment or recovery. In addition to the initiatives that will help reduce stigma, DDAP is continuing to work toward 3 additional goals of intensifying primary prevention, strengthening our treatment systems, and empowering sustained recovery. In terms of prevention, the administration has implemented more than 880 prescription drug take-back boxes covering all 67 counties in the state. And since 2015, more than 800,000 pounds of unused and unwanted medication has been disposed of safely. Our single county authorities continue to implement prevention programming in schools and communities aimed at preventing use and misuse. We're continuing to strengthen our treatment systems by ensuring care is delivered using evidence-based best practices. We've recently announced a tool which will assist individuals in accessing trustworthy, high-quality treatment services across the state. The Atlas tool will evaluate addiction treatment providers' use of evidence-based practices and publicly display this information to support those in need and their loved ones in finding appropriate quality care. Working to expand access complements the work of integrating quality metrics into practice. Pennsylvania is currently in the process of implementing the ASAM criteria, a standardized roadmap to treat substance use disorder. This clinical tool aids drug and alcohol practitioners in identifying and developing individualized treatment plans for substance use disorder patients, allowing multiple routes to get to the destination of long-term recovery. Our ultimate vision for Pennsylvanians is to live their best life, free or in recovery from addiction. Having a strong network across the state to prepare individuals for their transition into recovery helps to assure that they can maintain their recovery. Establishing sustainable funding sources and opportunities, encouraging family-centered recovery, supporting careers in the field of recovery, and promoting the pardon process are all ways to achieve sustained recovery objectives. Additional strategies to empower sustained recovery are being developed through the Recovery Rising project and will be shared in coming weeks, following the collection of suggestions from across the state to improve recovery support services. I know I've shared a lot with you this morning, so I'll wrap this up shortly. I wanted to briefly circle back to a point I made a few moments ago when talking about the impacts of COVID-19 and how we must have a shared understanding moving forward. With a shared understanding of substance use disorder as a chronic disease, communities are better equipped to help people with the disease gain access to needed harm reduction, intervention, treatment, and support services. Together, we can better manage the challenges associated with this complex public health crisis. Having strong partnerships at the community and governmental levels is so important. Often in government, for organizations to work collaboratively, silos must be broken. I'd like to thank the Regional Overdose Prevention Coalition and all of you for being partners in this process as we continue on this shared mission and passion of connecting individuals to the proper services and resources, ultimately reducing the impact of substance use disorder in Pennsylvania. In closing, I would like to take the opportunity, as I always do, to remind folks that help for anyone who is struggling is available any time of the day or night, and it's literally at our fingertips. Pennsylvania's Get Help Now hotline is available 24 hours a day, 7 days a week, 365 days a year. The number is 1-800-662-HELP or 1-800-662-4357. Whether you are an individual in need of services or a family member inquiring about services on a loved one's behalf, trained individuals are on the other end of the line to help navigate local resources and treatment options in your area. And that's regardless if you're insured, underinsured, or uninsured. Finally, there is strength in numbers, and your commitment, along with ours, to continuing this vital work will help make us all stronger. I thank you for your dedication. I look forward to joining you again in a few minutes to take some of your questions.
Thank you so much, Secretary Smith. That was wonderful, and we really do appreciate you being here. We're going to move forward and do the same thing for our other three panelists before we start our more interactive portion with discussion. Our next panelist is Dr. Sheila Vaccaria. She is the Deputy Director of the Department of Research and Academic Engagement for the Drug Policy Alliance. In that role, she helps everybody understand a range of drug policy issues while responding to new research with critiques and analysis. She has been actively involved in a lot of different conferences, and we're really, really pleased that she was able to join us for today to share her expertise. Thank you.
Thank you, everyone. Can you hear me okay? Yeah, all right. Well, it is my privilege to be here today, and thank you so much for joining us. I would be remiss before starting today's presentation if I were not to acknowledge the fact that we are now 2 decades into our current overdose crisis. Recent estimates nationally suggest that we lost upwards of 90,000 people to overdose deaths last year, and estimates may come in at even higher numbers. These were family members, these were loved ones, these were neighbors, these were valued members of communities, and I just want to acknowledge that loss of life in this moment. I'd also like to acknowledge that tomorrow, June 26th, is the National Day of Action and the Global Day of Action for Support, Don't Punish, a global campaign to fight against the war on drugs and to acknowledge the global harms of the criminalization of drug use. And so I have my Support, Don't Punish button on today. I work at an organization called the Drug Policy Alliance. For those of you who may not be familiar, we are the largest national organization fighting to end the war on drugs and to pass policies that are informed by science, compassion, public health, and human rights. We have been at the forefront of passing policies that promote the health and well-being of people who use drugs and people seeking recovery and people who are impacted by the criminal justice system. I'm going to talk a little bit about some of the federal policies that we are currently working on that may be of interest to you, and I'm happy to take more of your questions during the Q&A portion. So first and foremost, I want to acknowledge that drug decriminalization is a large part of DPA's current work. And this is important for a number of reasons. First and foremost, the criminalization of drugs is the legally sanctioned stigma and discrimination against people who use drugs. Although it is a lofty and mighty goal to fight stigma against drug use, as long as people who use drugs are uniquely the only people with a disease that's also a crime that deems them a criminal in the eyes of the law, stigma reduction campaigns can only do so much. And so drug offenses are the leading cause of arrest in the United States. More people are arrested for drug charges than a number of violent crimes combined. In fact, it was estimated that upwards of 1.5 million people were, or 1.5 million arrests were conducted in 2019. And this number has actually remained relatively stable. If you look at the bar below in the graphic, that light gray portion actually signifies that the vast majority of people who are even arrested due to a drug offense are actually arrested for drug possession within quantities and thresholds that were actually deemed for personal use and not for sales, manufacturing, or distribution. And when we talk about the war on drugs and drug criminalization, we cannot extricate it from it being a fundamentally racist and xenophobic policy. It's estimated that Black people are roughly 26% of all people arrested for drugs, even though they comprise roughly 13% of the population and use drugs at rates that are comparable to other racial and ethnic groups. To learn more about the drug war and to get more statistics about it, you can visit our website below. I will also drop it in the chat box later. So what are we doing to address this as the Drug Policy Alliance? Just last week on June 17th, the 50th anniversary of Nixon declaring the war on drugs, Representatives Bonnie Watson Coleman and Cori Bush introduced the Drug Policy Reform Act, the first federal piece of legislation to dismantle the federal drug war. I can't go into all the details, but I will go into some of them, and I encourage you to visit the website below for more information about the policy. But I will read here that our proposal for decriminalization, the Drug Policy Reform Act, takes these first steps in dismantling the punitive apparatus built up over the past 50 years, and to begin to refocus our federal drug policies, and the legislation shifts the authority to the classifying regulated substances from the DEA to the National Institutes of Health and the Department of Health and Human Services. If we truly believe that drug use is a health issue, it should not be under the auspices of a federal law enforcement entity. It would reduce and eliminate criminal penalties for possession of personal use quantities of controlled substances and moves away from an enforcement approach to a public health approach. In addition, the bill would eliminate harsh sentencing and mandatory minimums that we know have contributed to mass incarceration, particularly for people who continue to be targeted by law enforcement and have longer and longer criminal records because of that contact, thereby also being subject to longer sentences and harsher sentences. It also provides for the decarceration and expungement of records for those imprisoned under the current system and would help to eliminate the numerous collateral consequences of drug convictions, including public benefits, student loans, and other kinds of issues. And it abolishes the enforcement agencies that have been at the forefront of the harms. In addition, some other bullet points that I want to highlight to you is that this saved money from enforcement would then be reinvested into harm reduction and evidence-based treatment opportunities at the state level, grants that states can apply for to then be able to fund these programs. It also promotes investments in non-police crisis intervention for mental health intervention, for overdose intervention, and a variety of other kinds of calls. It removes all restrictions for methadone and buprenorphine on the federal level, meaning the X waiver and requirements for opioid treatment programs as being the only treatment provision sites for methadone for opioid use disorder, and it funds evidence-based drug education and prevention and moves that funding from the Department of Justice into the Health and Human Services for this. And it expands research on harm reduction, safe supply, alternative regulatory models, and others. And I don't want to be, I'd be remiss to also acknowledge that there is language to allow for overdose prevention centers or safer consumption spaces, as you may call them. Another key area of the work that the Drug Policy Alliance does is we really try to highlight the ways in which criminalization and contact with the criminal legal system actually happens in systems beyond just in carceral settings. So we had a project called the Uprooting the Drug War Project, which you can visit at uprootingthedrugwar.org, where we actually did 6 intensive reports on the fact that the drug war has actually taken root in other systems, such as housing, employment, public benefits, immigration, child welfare, and education. We know that having a drug offense can impact your ability to access SNAP and TANF, which are essential benefits for recovery and food and nutritional needs of people who may have a criminal record. We know that oftentimes having a criminal record can disqualify you from public housing or lead to you being evicted, another issue that can disrupt your ability to actually seek recovery and establish recovery. And another lesser known issue is that in 2019, ICE, Immigration and Customs Enforcement, conducted a drug-related arrest one minute out of every 9 minutes. So basically every 9 minutes, ICE arrested someone for a drug offense. So when we talk about the drug war and the systems in which it has taken root and the ways in which it's disrupted the lives of individuals, families, and communities, it's actually taken root in a number of these systems. And decriminalization is one of the only ways we can truly destigmatize drug use, but actually create the conditions for recovery and wellness that we know actually help people get their lives on track. Another key part of our work at the Drug Policy Alliance is actually fighting for marijuana reform. In the earlier diagram, I illustrated that roughly 85% of all drug-related arrests are actually for simple possession alone. And the vast majority of possession arrests are for marijuana possession. And that continues today, even as we move forward with marijuana legalization. And so, as I just said in the Uprooting the Drug War portion, having an arrest record, including for something like marijuana, is a huge barrier for people who might be seeking recovery or to improve the conditions of their lives and their families' lives. And we know that public support for marijuana reform has shifted dramatically. In 2000, roughly 1/3 of Americans supported marijuana legalization, and now upwards of 67% of Americans support legalization for adult use. And if you include the number of people who support it for medical use as well, this number turns up to about 90%, if not 95% of Americans. And we can see that we've moved forward in a number of states to advance medical access and legal access. And I think momentum is clearly growing. One of the things that we're working on a federal level is actually working to pass the Marijuana Opportunity Reinvestment and Expungement Act on a federal level, which would actually deschedule marijuana from the federal scheduling of drugs and then allow for reinvestment and expungement of records, reinvestment in communities most impacted by criminalization, and expungement of records of people who were previously impacted by federal marijuana scheduling and criminalization. It would still allow states to pass their own legislation, but it does mean that the federal government would no longer get involved in states that have moved forward with their own legislation. And so these are just some of the key national projects that we're working on in this current moment. And I'm happy to take more questions as we get to the Q&A portion, but this is my contact information. And I'll drop some of those links in the chat box as well. But thank you for your time.
Thank you so much. We're really appreciative of your time and expertise. We are going to move on to our next panelist, who is Tracy Pugh. She's a senior program officer with Vital Strategies Overdose Prevention Program. She has a decade of experience or more in the field doing research, policy analysis, program design, implementation, and advocacy. Thank you so much for joining us, Tracy.
Hello, can folks hear me and see my screen okay?
Yes, both.
Awesome. Good morning. Thank you so much for having me. My name is Tracy Pugh, and I am the senior manager at, for the Overdose Prevention Program at Vital Strategies. For a lot of my presentation, I'm going to try and be brief, although I always have way too many slides, full disclosure, but I really want to emphasize the partnerships and just what Secretary Jen Smith has emphasized, the essential need for collaboration, cross-sectoral collaboration, and that we couldn't be doing this work without our partners on the ground. And so I want to begin that the North Star, the goal of this initiative that we are a part of with Bloomberg Philanthropies, is to reduce death, to reduce overdose deaths. That's our North Star, and that is the work that the metric that we are really working towards as part of this initiative. How can we save lives? And so with that, how can we reduce the vulnerability to overdose death? The partnership began in 2018, part of the Bloomberg Philanthropies Overdose Reduction Initiative, and it was announced, Pennsylvania was our first state, announced in November 2018 with partnership, it was announced between Mayor Bloomberg and Governor Wolf. And as part of the initiative, Bloomberg Philanthropies pledged a $10 million investment in Pennsylvania over the course of 3 years. And so BioStrategies have been the stewards of that funding, although we've also worked with our partners as part of the initiative, the CDC Foundation and the Johns Hopkins Bloomberg University of Health, as well as the Pew Charitable Trust. And so in investing that $10 million in Pennsylvania, as well as our investment of $10 million in Michigan and investments in other cities and states, the 4 guiding principles to achieve our objective of preventing overdose deaths is 1, harm reduction. And I think that's been has been the big framework of our work since we hit the ground running in 2018. How do we engage and work through a harm reduction lens, meaning how do we center the goal of improving the quality of life, the well-being and health outcomes like mortality and morbidity for people who use drugs. And so it is intentionally inclusive of how we could do interventions that are supportive of people with active drug use, people who return to drug use. And so that is our overarching frame. And with that, it comes with the idea of do no harm, do no further harm. And with that is support, don't punish. Really appreciate Sheila for emphasizing that as well. And we are also targeted and oriented towards advancing racial equity, recognizing that Black, Indigenous, and other communities of colors have been most marginalized by the war on drugs and the most vulnerable traditionally, historically, to harms related to drug policy and in barriers in accessing services around drugs. And then with that, we also want to center health equity, recognizing that all other vulnerable communities, such as LGBTQ communities, people who engage in sex work, low income, rural communities, et cetera, have also been marginalized and face substantial barriers in improving their health outcomes. And so with those principles, we have been really engaging a slew of partners. It cannot be done, it cannot be understated how essential partnerships, including public-private partnerships are. Drug policy, substance use treatment, and just our general healthcare system is highly fragmented. Harm reduction has been marginalized and siloed from substance use treatment traditionally, but also other healthcare domains. And so the partnerships are really, and the cross collaboration is really essential to break those silos, to break those fragments, and to really just help understand and navigate and incorporate harm reduction interventions across the different systems that touch people who use drugs, from criminal justice systems to hospital systems to community-based social service systems, et cetera. And so I just really want to shout out our OPC, who's been a great partner, and the Prevention Point Philadelphia, who's also been really essential to making this partnership happening. Prevention Point Philly was one of our first partnerships on the ground and is one of the oldest, and just a generally really effective, engaging, and dedicated organization in this work. And so we're really appreciative of our partnerships. And like I said, we can't do the work without them. We do have statewide partnerships, such as the Hospital and Health System Association of Pennsylvania, which just had their capstone last few days, culminating to discuss their 2 years of work. They provide technical assistance and networking opportunities for over 120 hospitals across the state. And again, to emphasize partnerships, we came into this work really to build on the great and to support and supplement the great work that's already being done. And so the example with the hospitals is really, we helped to develop that initiative, which in response to and a part of and to supplement the work that the state had already began with the Hospital Quality Improvement Program, HKIP incentives, to incentivize hospitals to incorporate substance use disorder and opioid use disorder treatment in their emergency departments and systems. And so here I really want to just again emphasize that in addition to our state work and our local government work, that we have targeted county-based initiatives also across the state. And part of the, I think what has also helped us, in addition to targeting the most impacted counties ourselves, we've also done a series of RFPs. And I want to emphasize that what we've learned in trying to build partnerships, including low barrier RFPs and grants, is that we really have to understand that if you build it, it doesn't necessarily mean people will come. If you offer the funding and as much as low barriers we're trying to make it, we found that there were still counties and stakeholders that weren't able to apply, that were hesitant, that had misperceptions about what was the criteria. And so I just want to emphasize that when we're thinking about partnerships and building partnerships, there will be people that will consistently come to the table, and then there will be people and groups and communities that won't. And so I think that really requires us to be intentional about how we engage our partnerships, including us at Vital Strategies, as we take this reflection period as we come to the end of our 3 years of how can we be more engaging, how can we really target counties and communities and municipalities and groups that even if we offer and put out the RFPs are for different barriers, capacity issues, misperceptions, don't apply or really need us to really improve our messaging and our connections. And I think that's something to think about in all our work, that there are communities that we are missing, that we are overlooking, and that we just really need to be intentional about how we could be more open and engaging. And so I'm just going to go through really quickly, because time's going by so fast, through a lot of our work. Medications, naloxone, a lot of our grantees through ROPCD are doing a lot of innovative naloxone distribution work. Thank you, Secretary Smith, for mentioning the mail order naloxone standing order. And I really want to shout out Next Distro, a national organization that mails naloxone to individuals. And then with that, I also want to give a plug, and I'm going to drop it in the chat around a webinar that we were having next week featuring PCCD, especially, and a few others who will discuss bulk, no cost, bulk access through the state portal to naloxone for community-based organizations that was recently launched this year. And I'll also discuss how the Pennsylvania Sheriff's Association, one of our partners, is working to improve and engage local correctional institutions to distribute naloxone at the jails at reentry. And so those, so I'll drop that in the link. And then I just want to run through medications, working with correctional systems and improving access to buprenorphine has been a major goal of ours. We even have a toolkit. Again, the hospital work that we have been doing, harm reduction, we were intentional in making sure that our first partners on the ground, people that we spoke with, were harm reduction service providers to really help capacity build and invest in their work, but also understand through their expertise, the environment and the landscape around harm reduction in general. And so our Prevention Point Philadelphia partners, our Prevention Point Pittsburgh partners, and our Project Safe partners in Philadelphia were truly pivotal to that work. We do media campaigns. We're working on one with DOH. And then also, again, our criminal justice work to really reduce penalties and punishment as a response to drug use, and to help build understanding within the criminal justice system that support how to engage in supportive interventions instead to improve access to substance use treatments such as buprenorphine and methadone. And then finally, as we go through our work going forward, we really are trying to work more intentionally on addressing racial inequities, as we've probably seen in the news, racial inequities, while overdose deaths has been lowering, decreasing among white communities, it's been raising in Pennsylvania and including counties within Pennsylvania among Black and other communities. And so here you see that with the green line, which is Black communities, it's an increasing proportion of overdose deaths in Pennsylvania. And here, when you look at the rates, you see that overdose deaths in the Black community has been rising since 2018. And it has been more than white communities. So I want to end there to say that I really hope we continue these discussions around racial inequities as our goal going forward, and how we can expand access to harm reduction services and improve lives and save lives for all communities. Thank you.
Thank you, Tracy. We will definitely have a little bit more discussion on the racial inequities during our Q&A portion of things. I'm going to now introduce, even though Dr. Vakaria said, where our goal might be in terms of decriminalization, we actually are working in an area where we do have laws. And so one of the final panelists is, one of the points of discussion for our final panelists is going to be law enforcement and how law enforcement can participate in harm reduction techniques. So this is Jeremiah Daly. He is the executive director of what was formerly known as the Philadelphia Camden High Intensity Drug Trafficking Area, or HIDTA, and is now currently the Liberty Mid-Atlantic HIDTA. And he's been executive director for 17 years. Prior to that, he was a Philadelphia police officer, so has a lot of background in law enforcement, boots on the ground. And I'm going to let him talk a little about what kinds of initiatives law enforcement can participate in that helps reduce the harms.
Okay, good morning. Hopefully my audio is good and you can hear me. Please let me know if it's not. I want to share some power. You can?
Yes, you're good.
Okay, great. And I want to put some slides up here as well. So let me make sure we can get those rolling. And let's see if we can do this. I think we may have it. Okay, great. We can see the slides, yes? All right. So as Renee indicated, I've spent probably 43 years now in law enforcement in one capacity or another, going on as a Philadelphia police officer, and now for the last almost 2 decades, working exclusively in the drug enforcement arena as we've gone into the HIDTA program. And in that time, we've seen great changes in both the drug environment and how police and other parts of the law enforcement community and criminal justice system overall have responded to substance use disorder issues. And probably the oldest of them all is, of course, the drug courts. The more recent developments include law enforcement outreach in communities affected disproportionately with substance use disorder programs. And without question, there is still room for more law enforcement involvement in harm reduction efforts. But these are just a quick overview of some of the things that are going on currently, and we'll try to run through these pretty quickly. So amongst the things that we have going on already are the pre-arrest diversion and deflection programs that are in place. The grandfather of these is the LEAD program, which began in Seattle in 2011 and has been very popular, particularly in the Northwestern states areas, but has not gained great traction here in the Northeast or the Mid-Atlantic region. More popular is the police initiative, Police Assisted Addiction Recovery Initiative, PARI, which grew out of a number of agencies in the New England region, particularly Massachusetts. That has become dominant in our part of the world here, and has about 20 different agencies in Pennsylvania working with them. Both Lead and Parry provide models for law enforcement and how they can adopt harm reduction strategies that are consistent with their law enforcement missions, and at the same time improve the quality of life and reduce the number of overdose deaths in communities that are adversely impacted by drugs. Locally, we've seen three major efforts in the region, and more growing every day. The Pennsylvania Attorney General's Office Law Enforcement Treatment Initiative, or LETI, we've heard mentioned a few times, has been a great success in 10 counties now, in the 67 in Pennsylvania, including 3 here in southeastern Pennsylvania, that are part of a partnership, I guess you would say, between stakeholders in law enforcement, prosecution, public defenders associations, harm reduction and substance use treatment organizations that give law enforcement agencies policy models and direction and training to the officers that will enable these type of activities to occur. Most of them require the district attorneys of the county that they're operating in to be on board with this. And in southeastern Pennsylvania, we've seen just about all the district attorneys have some level of interest in reducing the caseload that they're bringing in for simple drug possession cases and other low-level offenses. The other low-level crimes could include the ones that are used to sustain drug use, acquisition in communities that often cause, relatively nuisance type activities, including things like retail theft and low-level complaints of that nature. But it's also designed to get the people who are suffering from substance use disorders away from the criminal justice system and into a treatment environment at the earliest possible opportunities. Probably the oldest in our region is the Hero Help Program, which began in Newcastle County, Delaware. That has evolved into a rather large program there that initially relied on people doing self-referrals, but now has expanded to include the diversion for low-level criminal offenses as well. And more recently, the Police Assisted Diversion Program, or PAD, that's underway in Philadelphia on a pilot basis in 3 of the 22 districts in the city. It has been showing some expansion and success by encouraging the persons contacted by police with substance use issues to enter into the treatment programs. Another area where law enforcement has been slowly engaging in, but more and more so of late, is post-overdose outreach. These programs tend to be more often involve emergency medical service, EMS personnel, but this outreach projects combine police, substance use treatment providers, social workers, and certified peer recovery specialists who get out to the scene or the location where an overdose occurred within 24 to 48, sometimes 72 hours after an overdose occurrence, and try to engage the individual who was the victim of the overdose and their family members or cohabitants to get referral to treatment, but also to educate them about safe practices and leaving behind the lock zone in some cases, how to conduct overdose reversals. Programs like this began and were very rapidly embraced in Massachusetts, North Carolina, and Ohio. There's actually an excellent toolbox that's available from North Carolina's post-overdose outreach programs that kind of goes step by step as to how these might be built. The law enforcement involvement in these post-overdose outreaches is not without critics, and it should be stipulated here that there's different tolerances and different opinions about this. Whether or not a uniformed police officer going out with a substance use treatment professional or someone that's had the lived experience of substance use disorders to engage, that sometimes that's off-putting, that the doors will end up being slammed in their faces when they see the law enforcement officers. So there's some mixed feelings about that. There's also some significant issues in the data exchange that's involved. It requires navigating the laws of HIPAA and other privacy issues that may vary from state to state as to whether or not law enforcement can provide information to the health community and vice versa to make these follow-up visits. One of the more benign and actually one of the older programs involving public safety, the Safe Station programs. They began with fire stations in New Hampshire, and there's been some adoption in different communities by law enforcement where, including Philadelphia, where people can come into a police district or precinct house and say, I need help. These programs are voluntary self-referrals, but officers at these stations will look to assist people with entering into the treatment stream. Oftentimes, there's no criminal charges for the possession of drugs or paraphernalia if they have it on their person when they come in to seek treatment. Those are disposed of. And they'll go so far as to arrange transportation and make the process of entering treatment that much easier to do. And of course, this is a fairly low cost solution. Finally, naloxone leave-behinds are one that have been utilized by a number of agencies, law enforcement, and other first responders to put the reversal drug in the hands of the people that are most likely to need it. We know that people who have just experienced an overdose are the ones that are most likely to repeat an overdose. And this can be done either at the time of the overdose reversal initially, or done on a post-overdose response a day or two later. This has a lot of advantages for rural communities where there's not as many police officers and EMS services, and for that matter, substance use disorder treatment services available. It at least provides an opportunity for people to have the naloxone in their hands. It's been more frequently adopted by EMS programs rather than law enforcement agencies. And it does have its limitations in that you really don't have the opportunity for further engagement, referral to treatment after that initial contact. Lastly, and emergent, I guess you would say, in our region and elsewhere, are the co-response and differentiated response programs that we're seeing develop around the communities. At the very beginning of our program this morning in our county updates, Mallory Perotti spoke of the co-response and differentiated response activities going on in Bucks County. These co-response programs pair up the specially trained officers and mental health substance use crisis workers to respond together to not only drug overdose situations, but situations where so often substance use and mental health disorders are co-occurring. The co-response is a little bit different than differentiated response. Differentiated response redirects calls for services to 911 to specialized crisis response teams that often have no police involvement, but it does put the services in the hands of the people that need it in the field through those non-law enforcement entities. The whole emphasis is on de-escalating the situation and reducing the amount of criminal justice involvement. Essential component to all of these is further training for first responders. And final point here would be that we have programs here in Pennsylvania too that stand out. And in full disclosure, I'm on the advisory board for the St. Joseph University CARE program. They're doing first responder training with a State Department of Health grant. They've already been training dozens of police agencies throughout the Commonwealth. In addition, the University of Pittsburgh School of Pharmacy Payru Center has their scope project. They're primarily concentrating in southwestern Pennsylvania, and are having great success in bringing law enforcement a little more education about substance use disorders, stigma, and strategies that can be used to overcome both. And with that, I will stop. So as I see I've gone over my time a little bit, and turn it back to you, Renee. Thank you.
All right, thank you. I want to let our attendees know that we received permission from the panelists to use first names so to be a little less formal. No one needs to call me Dr. Cassidy, just Renee is fine, and the same with everyone else. And I want to let you know that if you are interested in asking a question, that you can direct message Ann Ricksecker in your chat box. You'll see a list of names. Go ahead and message her. We will be starting with the previously submitted questions. And so we make no promises as to whether we'll get to your question, but we'll do our best in the next half an hour to have a discussion. I'm going to throw the first question back to Jen and Sheila, because one of the things that came up in both of your presentations was efforts to decriminalize certain aspects of things. And I'm going to ask you to take out your crystal balls and predict for me what is realistically a potential for happening. So Jen, let's start with Pennsylvania. Right now, we do have syringe services programs, but that's in certain areas only, and the rest of them are illegal. Fentanyl test strips, paraphernalia are illegal. You know, certainly we have no supervised consumption sites in this whole country. Can you tell us what is the potential for decriminalizing sort of anything, you know, in that sphere?
Yeah, so, unfortunately, COVID kind of derailed a lot of efforts and a lot of momentum and steam that had been built up specifically around trying to legalize syringe services and working on fentanyl test strips. However, I think in this past spring legislative session, we've kind of gotten a lot of those things out of the way now. And so those things meaning the COVID related pieces of legislation that everybody was arguing about and disagreeing about. So I think what we're going to see in the fall legislative session, which will start back up in September, is a focus on a lot more other aspects of healthcare, specifically related to the opioid crisis. So many legislators have felt like we've ignored the crisis during the pandemic, and that's their lens because they were doing that. You know, they were focused mostly on the COVID issues. We all know that we were, just as heads down focused on how we were addressing substance use disorder, particularly knowing what was happening with the pandemic. So I think there's going to be a lot of interest legislatively to look at this in the fall. We do have support from a number of members on both the fentanyl test strip issue as well as the syringe service issue. In fact, there's a House bill out there right now sponsored by Representative Struzzi around the fentanyl test strips. There's been language floating around. I don't know if there's an actual bill introduced yet this session about the syringe services, but I know that the language is drafted and that there is commitment from several members to introduce that legislation if it's not already out there. So I think the likelihood of those two things is very probable. The other thing that I think might creep along again in the fall will be discussions around legalization of recreational marijuana. And as part of that discussion, there's always this component of decriminalization. And I think that some folks will often, when approaching this topic, it's more palatable to them to talk about the decriminalization aspect than it is to talk about legalizing recreational marijuana. There's, for some people, that's like a big hump to get over between those two things. They can accept the decriminalization piece, but they're not really quite ready to say, I fully support legalizing. So I think that there actually is still a really good possibility that either this coming fall session or perhaps the next legislative session we'll be talking about and looking at decriminalizing. So I think that there's lots of opportunity for movement, and I would encourage groups like this not to let off the gas pedal with putting some pressure on. The summer is a great time to make sure you're doing some advocacy and outreach to members of the General Assembly, because they're sort of out of session, they're in their home districts. So hearing from constituents during that time is really, really important so that it shapes their perception of what they want to focus on in the fall session.
Thanks. And Sheila, I don't know, you've mentioned that something was introduced, but I don't know if you have any sense of the likelihood of anything getting passed.
I think when it comes to federal policy reform, and even at the local and state level, I think the introduction of landmark legislation in and of itself is a huge feat that symbolically and in truly can help shift conversations. And I think that that's what we at DPA stand for, is really being at the forefront of shifting conversations. We understand that people are going to take time to move along and to kind of come along to some of these issues, but we don't think that that's a reason to stop, right? And we were actually working in Oregon for the past several years, and we had actually drafted that piece of legislation to decriminalize drugs in Oregon. What we found is that in a lot of places where we've been able to advance some of the more innovative policy reform, it's actually been by going directly to voters in states that have ballot measures and ballot initiatives. And I think one of the reasons why we saw that success in Oregon was because we were able to actually bring our message to people. And, health was at the forefront of the name of our piece of legislation, because we truly believe that if we want to take a health approach to drug use, we need to deflect people from law enforcement contact directly to case management and referral sources to really then find out what their needs are. And so, I think that Oregon is a great model and a great example, and I think people are going to wait and see. But I'd love to invite Jerry into this, because actually I think your presentation highlighted the very clear ways that we can de facto, through our practices, actually decriminalize drugs. There's de jure decriminalization, which is putting it on the books, and then there's de facto. And that looks like law enforcement at the point of contact, engaging in diversion or making referrals or deflection, as you call it, those safe spaces that you had also described in which people with possession charges were deemed to need other services. I think also there's space here for prosecutors, progressive prosecutors, to say, you know what, I'm not prosecuting possession charges. And it doesn't change the laws on the books, but it starts changing practices and hearts and minds, and you start seeing some of these changes at the grassroots level. And so I think that there's a lot of possibilities for an incremental approach that's unique to a community and where they're at. But I do think that it's really important for us to keep the goalpost. If we truly, truly want to say that substance use and substance use disorders are a health issue, they cannot also be against the law. Like, it cannot, addiction cannot be the only medical issue that's a crime. And that is what our laws have put us in the place with right now. And there is something fundamentally broken with a system that insists that people with a health issue are also criminals. And as long as we're competing with the apparatus of law enforcement, we will never truly destigmatize drug use.
Yeah,
well, thank you.
Sheila, let's have Jerry talk about, within the law enforcement community, what are the attitudes towards taking some of these steps, and what's the likelihood that we can get from a sort of a resistance to any kind of measure to this, to incremental reform, to actual a big step such as decriminalization?
Well, I'll be frank as possible here. We are still a long way away, in my mind, from generalized acceptance of possession of controlled substances being tolerated in not only the law enforcement community, but many communities at large. We're still quite a distance from there yet. But I do think there's increasing recognition, particularly among the leadership in a lot of law enforcement communities, that we, to use the old hackneyed expression at this point, we're not going to arrest our way out of the substance use disorder problem. I think there's truth in that. But I also don't think we're going to treat our way out of it. I don't think we're going to be able to get our way out of it from harm reduction only. We have to do things collaboratively. And that's I think the key to this is we will continue to disagree on particular policy issues from time to time, but we will still be able to work effectively in reducing the community harms and individual harms that we see arising from substance use disorders if we can put aside the differences and focus on the shared goals.
Agree. I want to shift gears a little bit and invite Tracy into the conversation to talk a little bit about funding. You mentioned the essential nature of partnerships, as did Jen. But can you talk a little about how people can obtain funding? What are the sources? Can you talk a little bit about, beyond obviously vital strategies, what methods can groups go to seek out funding? And I think let's start with Tracy and then maybe have Jen address that as well.
Sure. I think I want to first start by saying that harm reduction has, I've said this before, historically been marginalized, and that includes from main funding streams, from foundation work, from healthcare reimbursement systems, from government investments. I mean, for just how recently syringe services were barred from federal funding. And so the Biden administration is turning some things around, but we really have to recognize that it's been highly difficult to fund this kind of work because of the stigma and because of notions of enabling, or because of notions of abstinence as a goal rather than, frankly, saving lives. And so what we really need to realize in the funding conversation is we really need to start pushing funders, including government agencies, including local governments, including state governments. Like, advocacy is the real thing that impacts the funding conversation, that impacts the budget conversation. And so we really have to acknowledge the importance of advocacy. And if we're talking about shared goals, in these funding conversations, we have to emphasize that our goal is to save lives. Like, that is the overarching goal. What is saving lives? What is not saving lives? What is preventing saving lives? What is disrupting services? What is disrupting capital in the community? So that, I think, is really important context in the funding conversation. With that, there is some hope on the horizon. The America Rescue Plan Act by the Biden administration has made one of the first and most substantial investments in addressing substance use disorder through harm reduction. Approximately $30 million allocated for harm reduction services. And so that is unprecedented and exciting. And so I urge advocates and state agencies and local agencies to really keep their eyes open for that. It'll probably go through like several different agencies to look at the CDC, SAMHSA, also probably through several justice agencies as funding like this generally tends to go through. But I think it's really exciting, and we should really think about how to invest that in harm reduction services, such as syringe services. And then the second thing I will emphasize is the opioid settlement dollars that are in the pipeline. It's highly complex, way more too complex for me to get into. That's a lawyer conversation, but it is a conversation that is starting to happen, and that we again have to look at how dollars will be going to the county, dollars will be going to the state agencies, but how can we advocate for that funding to be invested in harm reduction services? So, aside from there's a shift in how agencies are approaching harm reduction, SAMHSA, CDC, et cetera. But there are also opportunities that don't have those clear allocations where advocacy is really important. So I'd say look out for that. And then finally, when it comes to just private funding, I think we as funders need to recognize that, that again, we put the RFP out, that doesn't mean they're gonna come. I think we have to recognize harm reduction service agencies, overdose prevention entities have limited capacity. Have limited grant writing capacity, have limited conceptions and notions of what harm reduction even means to identify that they can qualify for these RFPs. So I think we really have to, as funders in all capacities, be cognizant of that and how we can make these funding opportunities as low barrier as possible. And then finally, there's reimbursement mechanisms, which are also very complex and tedious and difficult. But that's another one where, again, advocacy needs to push, and we at Vital Strategies are working on it, how can we integrate and how can we bolster access for harm reduction services to be reimbursable?
Thanks, Tracy. You set the stage beautifully. And I think that this conversation actually dovetails off the last one, right? So one of the biggest challenges in our state, now that we have the opportunity to use federal funding to do it, thanks to the federal government decisions, that doesn't change the ability at the state level that these services in some cases are still illegal. And so while the feds have said, yes, you can spend our money on it, our state level officials are going to say, you can't spend this money on that because it's not legal here. So, you know, I'll continue to plug for, please advocate to your legislature, please talk about fentanyl test and syringe service programs. If we can make some movement there, it really does open the door for us to use a lot of those federal dollars. But I won't be a complete Debbie Downer. And I will say that just because there are certain things that we can't fund with those dollars doesn't mean there aren't ways for us to help fund harm reduction organizations or services, right? So the law is very specific about test strips and about syringes, but you all know harm reduction organizations do a lot more than just those two things, right? There are other kinds of case management services, connections to employment, connections to housing, you know, all those kinds of different things that are all very fundable services. So while we may not be able to write a blank check to an organization and say, use this for whatever you need to use it for, we might have to get specific and say, we're going to give you some money and it has to be used for things other than the purchase of syringes or the purchase of test strips. So it just requires us to come back to this collaboration point. It requires us to have some conversations about what kinds of services do you need help funding and how can we use our dollars to do that. And I think Tracy's point is so valid, and this is where I'll end in my response, which is the federal government and states have been pouring money into treatment for years. And then we came along with a prevention set aside in the block grant that required a certain amount of dollars to be devoted to prevention. So then it was treatment and prevention. And so the two areas that have really been lagging in a lot of states are the recovery support area and the harm reduction area. So I think it's incumbent upon all of us across the nation to really look at how we're using those dollars and making sure that we're spreading them widely across the continuum, especially given the fact that we know the process isn't linear, right? It doesn't roll from prevention, intervention, treatment, recovery. There's bouncing back and forth, and there's people that go right from intervention or harm reduction strategies to recovery, and they hop right over treatment. And then maybe they'll hop back to active use and then to treatment. And so there's this constant movement and shift and shuffle as people navigate the disease. And so instead of us kind of segmenting funding based on this really linear thought process, we have to be more careful that we're really funding care for a whole person. And that means jumping around and all across and making sure that our funding sources have the availability to support services at all of those levels.
Thanks, that's a great point. And actually it sort of addresses one of the questions that came up was connecting harm reduction practices to recovering, expanding the idea that a full spectrum of harm reduction, treatment, recovery, all of it, prevention, all of it does need to be addressed and funded. So you actually answered the question before I even asked it very nicely. We have several questions about data, and I wonder if maybe Jen and Jerry could talk to us a little bit about what has happened in COVID. Are we seeing an increase in overdose deaths? You know, Zoe mentioned, and I think several people mentioned, we've seen an increase in, or a shift, I should say, in the affected communities. But could you speak generally to just some statistics for the state and for this area, and maybe Jerry, if there's some statistics, you know, OD stat, OD map, those kinds of things that you want to point us in the direction to look at later.
Absolutely. Yeah, we have seen an increase in overdoses. One of the slides that I shared earlier showed a graph over the last several years of what those numbers looked like. So in 2020, as of the beginning of June here, the 2020 numbers stand at 5,045 deaths. Those numbers are still trickling in. This is one of the challenges that we've had in Pennsylvania for many years, is that collecting overdose death data is really lagging. Oftentimes it takes 6 to 9 months after the end of the year to get a finalized count. So that's where we stand as of June. That number will only increase. It will not decrease. So at this point, it is still below the peak of where we had hit in 2017, which was a little over 5,400. We are thinking that we probably won't quite reach that peak number from 2017. So I think we'll stay under that, but we do believe that it will go up still slightly from where it is as of June. I will say that of those 5,045 deaths from 2020, 1,200 of them were from Philadelphia, and 600 of them from Allegheny County, which is where Pittsburgh is. So after those two biggies, which are normally our largest locations for overdose deaths, following that, the counties that had the largest numbers, and this would range anywhere from 100 to 200 overdose deaths per county. Those counties were York, Lancaster, Delaware, Montgomery, Bucks, and Luzerne. So those are seeing fairly high numbers. It's not surprising to us to have seen the increase in overdose deaths. We do believe that usage went up during 2020. We believe less people were seeking treatment during 2020. Access went down at some points because facilities were closing their doors due to COVID cases or potential COVID cases. So I think it's really important that we don't let up on the gas pedal. I think we've proven that we do know how to bring that number down. We did that in 2018 and 2019. We just weren't prepared for COVID to enter the scene and really change the circumstances. So we have to resolve to continue working on and expanding all the efforts that we've been working on to date. And I think sort of the big piece to helping contribute to the continuation of all of those things is adding a real emphasis on harm reduction. And hopefully we get some legislation that enables us to do that in a much bigger way than what we'd be able to do today.
So I'll just add to that at a more regional level. All 5 of the southeastern Pennsylvania counties saw some level of increase in overdose deaths between 19 and 20, based on the preliminary data, as Secretary Smith pointed out. You know, these numbers are subject to change, but nobody's going to fall below the 2019 overdose fatalities. The most pronounced increases were in Philadelphia. And to some degree, you know, in Bucks County as well, we're seeing it escalate at a more rapid pace than in Chester, Montgomery, or Delaware counties. The pandemic itself created some really unusual confluence of factors that changed things up a little bit. Probably the most significant part was a short-term interruption of supply lines coming across the U.S. Mexico southern border. Organizations that were trafficking drugs adapted to that and found other ways to move the substances that were involved in a lot of these overdose deaths through other means. One of the things that also was very clear from 2020 data is that fentanyl is the #1 killer. It is now very unusual to see something in a wax fold or capsule purported to be heroin contain just heroin. More often than not, probably 80, 85, and in the case of New Jersey, 95% of the samples that were examined had fentanyl in them. The question is how much fentanyl, what type of fentanyl, and you know, will other adulterants be involved as well? xylazine is also being introduced into the market as well. And this is an aggravator of, the effects, an accelerant, if you will, that can lead to overdose.
I see Tracy with her hand raised. Is there something you'd like to add?
Yeah, I mean, I think we would be remiss not to acknowledge the racial inequities that's happening. Again, I started on this and showing that we really need to start disaggregating this data. And I also noticed that, we do tend to focus on the numbers itself, which are important and do indicate to some degree the burden. But I think what we've less been discussing just generally in this work has been the rates. And so even though Black and Hispanic and other communities make up a less percentage of the overdose deaths, when you look at the rates, you see that as smaller communities, they're more impacted. So a greater burden on their communities is occurring. And I know we talk a lot about Black communities and white communities, and part of that is just the difficulty in collecting that data. We need to be more intentional about collecting race data and ethnicity data. In my looking at data, it can be really difficult to find, especially from a rate perspective. And so, Pennsylvania, why the Latinx community has also been heavily impacted. And there are a lot of pockets of Latinx communities throughout Pennsylvania. And then I'll also add that looking at the collar counties, I ran some quick data from the Pennsylvania data sources, and each county is showing an increase in overdose-related death rates in Black communities. And there is also indications of Latinx communities also being targeted. So I think this is the data source that I used. So there are data sources that could assist you in looking at that. But in my experience in working with counties and doing these grants, when we ask about racial equity and racial inequity, how they're addressing it, it's not discussed. And so the response to that question is often some confusion. But I think, to be fair, the data can be really difficult to access and really difficult to disaggregate by race as well as race by gender. And the one last thing I'll say is when we're talking about collaboration and cross-sectoral impact, and yes, deaths are our North Star, I think we also need to start looking at this data of who's accessing treatment, who's accessing evidence-based treatment, and who's not. Who's being put into jail for low-level possession, for using substances, and who's being deferred to treatment and giving, especially buprenorphine treatment. So I'd say there are already studies indicating that Black and Latinx communities have substantially lower access to buprenorphine treatment across all payers, whether they're on Medicaid or commercial payment, it doesn't matter. And then I'm really thankful to have Sheila here, because Drug Policy Alliance and their work, Uproot the Drug War, really goes into the data around punishment and penalties and arrests, and how Black communities and other communities of color are hyper-targeted for drug use, and also in other realms such as drug testing of pregnant women, referrals to child welfare system. Gosh, I mean, I could go on and on, but I think we really need to start looking at that data and then start thinking to ourselves, what are we doing in those specific communities? Are we distributing naloxone? Are we doing overdose prevention in those communities? And so I think looking too much at the aggregate number, and we're seeing success, but it's we really need to start breaking it down and saying success for who's driving this. And then the last thing I will say is that with COVID, what we're seeing is Black and Latinx communities have experienced the most hardships during COVID, the most hardships. And so if you're experiencing housing hardships, employment hardships, yes, that is going to drive you to crisis. That is going to drive you to unmanaged, chaotic drug use. But the overarching issue is really the stress of not having jobs, not having income. Food insecurity over COVID has gone astronomically. Food insecurity. So I just think we really need to think about that, especially when we're involving punitive responses and how that compounds the issues of employment, of housing, of food access, of community cohesion, particularly in Black and Indigenous and other communities of color. So that's my little rant, but I think that's the conversation, that's the data that we really need to start looking at, because white rates of overdose are going down. And so who's being left behind?
Thank you, Tracy. I think that
And I'd like to jump in if I could.
go ahead.
So one of the things we have seen on a national level, just to piggyback off of everything, is that from 2017 to 2018, when it looked deceptively like overdose rates went down across the country, Black and Latinx overdose death rates actually went up when we looked at it on a national level. And part of this is because since the beginning of this crisis, it has been framed as a white suburban rural crisis. So our interventions have been targeted for certain populations in mind. Our public education campaigns have been targeted with certain faces in mind. Our regional approaches to messaging have looked at certain communities and neighborhoods. And what's happening is that our Black and Brown communities, particularly in urban regions and in those rural areas, West Virginia not only has the highest rate of opioid overdose death in the country, it has the highest rate of Black opioid overdose rate in the country, and no one talks about it. There's about a dozen states where the Black overdose rate is actually higher than the white overdose rate. And then a handful of states where the Latinx overdose death rate is higher than the white overdose death rate, particularly among Puerto Rican, stateside Puerto Rican communities. And so we absolutely need to reevaluate how we are framing this crisis. This is a polysubstance use crisis as well. The astronomical increase in the involvement of cocaine and fentanyl-involved overdose deaths, methamphetamine and fentanyl-involved overdose deaths has also been something that with this simplistic opioid framing, we've completely overlooked. And one of the reasons why we at DPA actually call this an overdose crisis is because we don't want to fixate upon substance or class-specific interventions when some of these interventions that address these issues are much bigger and broader reaching. And so absolutely, our messaging needs to be linguistically and culturally appropriate for communities, but also acknowledge different patterns of use. What we know is that in certain urban centers where Black overdose death rates are going up, it's also because they're sniffing and they're not injecting. And we need to do more deep ethnographic research with our communities of color about their preferred routes of administration, because also if we prioritize syringe-only interventions, we miss out on people who smoke their drugs and people who snort their drugs. And for people who may identify as primary stimulant users and see our playbook on syringe access is grounded in opioid injecting practices, which are very predictable. You got 3 to 4 times a day now in the era of fentanyl, it may be more, but injection practices when you're injecting stimulants looks far different. It's often a very different pattern. The injection needs are going to be different. The equipment needs are going to be different. And harm reduction for people who inject a lot of these drugs is shifting to smoking. So what are we doing to help people shift their routes of administration and giving them access to safer pipes and other equipment and strategies for snorting rather than injecting, but also all of these other things. And I could keep going, but I just wanted to also just kind of add some of those layers in because, again, harm reduction is more than its interventions. And these days, the interventions we know of are syringes and naloxone. Right. And then not to minimize the fact that your state made some of the most progress on safer consumption spaces in the country. And I want to acknowledge the courage of your community, your activists, your drug user leaders in actually being at the forefront of actually pushing our federal government just in the past several years. We are watching, we are supporting you. We want to see you succeed. And Pennsylvania can be a model and in so many ways is. And as a national representative, if I can be a national representative, like we are with you, we support you, and we want to see you succeed.
I feel like we could probably have a whole conference, a whole day conference, just on some of the things we touched on for 30 seconds. I'd really love to have more time to talk about the racial inequities and not just gathering the data, but action with this data. We all too often say, well, we've got to study it. Do we think this is happening? And how do we know? We need the data, but we need the action. I think we could have a whole conference on the psychostimulants and polysubstance use. And we've seen that. There have been other conferences. I love the discussion that we've started. We have unfortunately already run out of time, though. We'll have to have you invited back for some further discussion because there really is so much to delve into.